from the clinical aspect. So my responsibilities have tripled, so I can't quite keep up and give you guys what you would need. So that's why I'm stepping out of this role and moving it on to people more qualified than I am. The other thing that's really exciting today is this is a trial. We want to video these things, have them readily available so that our major CEs that we really need to be signed off on can be recorded for you guys, and you can get them then at a later date when you're on duty and you get called away, that type of thing, because it's not fair. This is a new protocol. Please come in, darling. How are you?
Good, how are you, sir?
Good. You're fine, darling. So, with that being said, Brenda Chrisman here from our marketing department and now foundation director, and Marnie Oak, and I'm only a little proud of that one, that Marnie's my daughter. She is going to be involved in all the recording and reaching out to the public for advertising our hospital and working from the marketing standpoint. So this is exciting for us, but today what's really exciting is ketamine for all of us to use. We've been using it in the ER quite a while. We are going to use ketamine for our purposes in EMS as for excited delirium only. It is not for RSI. Our docs did not approve RSI, but they did approve ketamine for use in excited delirium. So it's really important for us to get educated right from the man himself about ketamine, what goes along with ketamine, okay? So this is Nels Cooper Brannon. He's an intern pharmacist up here at the hospital with us. He's a third-year student at Midwestern University in the pharmacy program, and that's down in the Glendale area. He'll graduate with a PharmD or a doctorate in pharmacy, and he graduates June 1st of this year. This has been a 7-year long stint for him, and he is more than happy to be getting out of the student role. Yeah, yeah, for some of us, Dan.
It's like a Tommy boy. Yeah, they're called doctors.
Yeah, exactly. So I'm really excited. He goes by Cooper, and he's already been so beneficial to help us at the hospital with our programming, doing med reconciliation. So it's my pleasure to introduce him. Make sure you remember the date he graduates.
Thank you. So, like she said, I go by Cooper. My first name is Danish, my last name's Irish, and Cooper just came from a television show. So, yeah, no uniqueness about that. But a little bit of background on top of that, I am married, I have a wife and 4 kids. I did do 4 years in the United States Marine Corps, served in the infantry, did 2 tours overseas, got wounded my 2nd tour, and then had the opportunity of coming back and signing to play for the San Diego Padres for 3 years in the minor leagues. Didn't make the big league team, but had a great opportunity of meeting some of my heroes like Greg Maddux and Trevor Hoffman, and got to pitch in the big league spring training games down here. You might have saw me. I was number 67 with no name on the back of my jersey. So unless you were my family, that was the only way you knew me, or they said my name. But had a great stint with that. And I just realized that, you know, I was not going to be a lifelong guy like Greg Maddux or Trevor Hoffman, and I just needed a real job, you know. So I looked at my wife, we had a couple kids at the time, and I said, you know what, I want to do something that has longevity, something that is going to be beneficial for us in the future, and I like helping out people, I like educating people, and so I decided to become a pharmacist. Basically, what a pharmacist is we're nerds, man. I mean, it is a nerdy field. You have to like chemistry, you have to like calculations, you have to like organic chemistry, and it's a lot of work. But I started back in 2010 after I finished playing baseball. I finished early 2010 and started spring, and here I am today, and I'm getting ready to graduate June 1st, 2017 of this year. So my wife and kids are excited, and we're ready to make that move. So I've had a great experience here at Wickenburg Community Hospital, and hopefully if the opportunity presents itself, I could have an opportunity of working at the hospital. So with that being said, let's talk about ketamine. Now, one thing that Tammy, I'm not sure if you said, there will be a short quiz at the end of the lecture. So if you do have paper, if you don't have paper, make sure you grab some paper. I'm going to air quote some little TQ questions, test questions. So yeah, exactly. One thing I do with my kids when I read with them, I do a lot of voices. So any of the parents in the room, I'm sure you know. I usually like to break out into my Keanu Reeves and kind of be like, yeah, man, just totally listen to this one right here, you know, like type deal. So here we go. We'll get started. So like she said, we're going to talk about ketamine hydrochloride for excited delirium. Okay, so these are the objectives. We're going to define excited delirium. We're going to look at the manufacturer, drug information, mechanism of action, the pharmacokinetics, dosing and administrations, toxicology, medication safety, and patient education. I felt like these 7 were very important for us to hit on and for you guys to know as individuals who are going to be administering this medication, okay? So what is excited delirium? Does anybody by chance, I mean, here's the thing, I always like to ask the questions, even if it's something that we know, because in the medical field, the last thing we want to do is assume. Somebody told me some great advice. Always assume you don't know, because then there's room for less error. Basically, you're recovering. It's like when you're walking on a pathway, right? In a grass newly filled. The way our brains work, the way we memorize things, if you keep walking down the same path every day, you keep studying something every day, that path, that grassy knoll turns more into a path, and it helps you to make those connections in the future. And that's something that I like to take advantage of and do every day. So Dr. Google says that the definition of excited delirium is a controversial proposed condition that manifests as a combination of delirium, psychomotor agitation, anxiety, hallucinations, speech disturbances, disorientation, violent and bizarre behavior, intensity to pain, elevated body temperatures, and superhuman strengths. It's almost like we pretty much just summed up every long adjective in the dictionary, but this is what excited delirium is. It's pretty ambiguous. So let's take a look at the manufacturing drug information. So the generic name is ketamine. Okay, it's applied as either an intravenous solution or intravenously or as an injection solution. And here are the concentrations that it normally comes in. I can't remember exactly the concentration that we have on stock at the pharmacy, but that shouldn't matter as long as we know how to calculate, which we will go over in the future slides. It shouldn't matter what concentration we carry in stock. You should be able to know how to calculate the correct dose for patient safety and efficacy. So they do come in for intravenous 50 milligrams per 1 ml. Injection solutions are 10 milligrams per 1, 50 per 1, and 100 per 1. Those are usually the standard concentration they come in. Now the brand name is Ketalar, okay, and it's supplied as an injection solution in the same concentrations as the injection solution for the generic. Now you might notice some bolded red, okay? Regulatory status for this drug, it is a Schedule III. It's also, the drug class is, it's a general anesthetic. And here are a couple of the labeled uses are either induction or maintenance of general anesthesia. And then I just listed for your convenience, these aren't necessarily important because we're not using them for it, but there's some off-label uses for you to take a look at. Okay, so this is where it gets nerdy. So bear with me, I'll try to make it interesting. This is the mechanism of action for the drug. So it produces a cataleptic-like state in which the patient is dissociated from the surrounding environment by direct action on the cortex and the limbic system. Ketamine is a non-competitive in-methyl D-aspartate receptor antagonist that blocks glutamate, which is a neurotransmitter. Low sub-anesthetic doses produce analgesia and modulate the central sensitization, hyperalgesia, and opioid tolerance. And basically what this does is it reduces polysynaptic spinal reflexes. I'm going to explain all these highlighted on the next slide, but I wanted to draw your attention to kind of let you see how it occurs and what's going on mechanistically in the body. So basically that substance, the normal substance, is the yellow triangle, which would normally be like, say, like a glutamate coming in on a receptor, right? Well, that active site is normally where that glutamate would bind to do whatever function it does to cause naturally in the body. Well, that allosteric site is where our drug binds to, that non-competitive allosteric site on the backside of Mr. Pac-Man. Okay, what that does is it's going to bind there and it's going to block that yellow triangle, which would be like our glutamate. And if you notice, it goes almost from like a 45 from the beginning, where the active site shows on the left-hand side, and it goes more to like a 90-degree angle, okay? Basically what it's doing is changing the formation so that it basically, that glutamate can't come in, and it's almost like a lock and key. It's like the key doesn't fit right, so now it's not going to produce the chemical reaction, the natural physiological reaction that it should have occurred. So it's not necessarily an antagonist in the fact that it blocks, like most drugs, will bind into that active site and prevent the glutamate from coming in, like a security guard saying, hey, sorry bud, you're not coming in tonight, right? Well, in this case, it's just doing it in an indirect way. So just to orient you so you know kind of what's going on there mechanistically. All right, so here's the definitions of these terms. So cataleptic-like state is a condition that occurs in a variety of physical and psychological disorders and is characterized by a lack of response to external stimuli and muscle rigidity to so that the limbs remain in whatever position they are placed. Kind of makes sense, right? What are we using the ketamine for? Patients that are overexcited, maybe non-compliant, not all there, delirious. We're going to give them the ketamine to kind of relax them and calm them down, right? And that's basically what, if anybody was to ask you, well, what are you giving them this drug for? Basically, we're trying to put this patient in a cataleptic-like state for their benefit and for our benefit, okay? Next, cortex and limbic system. This supports a variety of functions, including emotions, behavior, motivation, long-term memory, and olfaction. Basically, olfaction is your olfactory, your sense of smell. Emotional life is largely housed in the limbic system, and it has a great deal to do with the formation of memory. Now, going back with the glutamate, that's one of the things that this thing is binding to prevent from functioning properly. It's an anion neurotransmitter of glutamic acid, a chemical that nerve cells use to send signals to other cells. Glutamate is involved in cognitive functions such as learning and memory in the brain. It is by far the most abundant neurotransmitter in the vertebrate nervous system. It is used by every major excitatory function in the vertebrate brain, accounting in the total for well over 90% of the synaptic connections in the human brain. Non-competitive, there's the definition for non-competitive receptor antagonist. It binds to the allosteric, like I spoke and told you guys about, to prevent the activation of the receptor. And polysynaptic reflexes, a reflex condition that involves an electrical impulse being transferred from a sensory neuron to a motor neuron via at least one connecting neuron in the spinal cord. Okay, so an example would be like stimulation of pain receptors in the skin, where it initiates like a withdrawal reflex, right? When you touch something, you withdraw with your reflex, which involves several synapses with several motor neurons and results in the removal of the organism or the part of the stimulus. Basically what this is saying is if this drug's in me, it's decreasing my polysynaptic spinal reflexes. If I go or a snake bites me, I'm not gonna like jump, flare, or if I touch something hot, I'm not gonna flare. I'm just gonna be there and it's gonna send the signal, but it's not gonna do anything. My reflexes are completely decreased, okay? So maybe that's something good. I didn't think about it until just now, but maybe that's something good as individuals who are administering this drug to be aware of your patient's surroundings. You know, maybe there's, you know, for whatever reason, I don't know, something sharp next to the bedside or wherever you're going to be at. Just kind of be aware of the surroundings of the patient, because they're not going to necessarily be as aware of their surroundings. Now, the pharmacokinetics of the drug, this is where we really get into the pharmacy aspect, okay? The onset is about 10 to 15 minutes for intramuscular injection. The duration is 15 to 30 minutes, single dose, intramuscular. Okay, the drug concentration levels are basically from a therapeutic drug concentration. Like, so basically when we say therapeutic, that's what we want. This is a good concentration level for if we were to ever pull any blood and lab levels. If we were anywhere from 40 to 200 nanograms per milliliter, that's a good dosing concentration, okay? And that could help us out in the future for basically kind of seeing, okay, are we at therapeutic dose? Because there's not really, because of the quick onset and duration, and as we'll talk about in the future, the half-life is fairly short. You can administer this drug often, I mean every 10 to 15 minutes, but we do definitely want to, I mean, and that's up to, you know, you guys, your dosing protocol, so I can't necessarily get into that, but you know, sometimes that first dose is going to work for these patients and you have to do an additional dose. So, and we'll get into that and talk about that. But the drug concentrations, like I said, 40 to 200 nanograms per milliliter. The absorption, the bioavailability is really high. It's 90 to 93%. I mean, of course, we're injecting it right into them, so it's going to have a high bioavailability.
Cooper, can I step in just a minute? So for our protocol, you guys, it has been written and the new protocols will be coming out. I've got them at the printer right now. So ours is for a one-time dose only, but we did give you the option then to give a benzo in addition to the ketamine, should you need it. You can give ketamine alone, but a one-time IM injection of ketamine, then you can add a benzo if you need to. Okay, so that's what our protocol will say, so.
All right, sounds good.
So there.
Which actually, I later on in the slide, I actually addressed that, so that's good. Excuse me, the distribution sites. So this, you know, in our blood we have a lot of protein, so it can bind to the protein, 47% of it. So what that does is it's going to help distribute throughout the body very readily. It will bind into the tissues. So for the tissues, it's going to go straight to the brain, heart, and lungs initially, and then it'll be redistributed to the muscles and the peripheral tissues. So like I said, it has quick onset and a short duration. The distribution kinetics, the half-life. Now the half-life, this is the half-life of the kinetics of the drug. It's 7 to 17 minutes, and the volume of distribution, basically volume distribution is 2 to 3 liters per kilogram, and basically that just means our blood, I don't know your guys' everyone's background, so if I get into it too much, let me know. But you know, obviously our vascular system pushes around everything to the vital organs, right? Well, it's the same thing. Our vascular system is like the highway for drugs. So it's going to travel, especially if it binds to these proteins, it's going to deliver it very readily throughout the body, okay? So it's like catching a taxi cab and it's going wherever it wants to go. The metabolism, it's metabolized by the liver so that it can be broken down and into its active form. It's extensively metabolized there. Its active metabolite is norketamine. It's excreted, 95% is renally eliminated and only about 5% is excreted in the feces. And its drug elimination half-life is about 2 to 3 hours. So like we were saying, you know, it's got short onset, short duration, and a short half-life. All right, so dosing and administrations. Our adults and geriatrics are exactly the same. The initial for WCH stands for Wickenburg Community Hospital or the ER, wherever you're going to be at. The normal dose will be 4 to 5 milligrams per kilogram. Okay. air quotations, hashtag stomp, for a single dose, and that's IM, very important. Remember, we're only doing ketamine IM. If an inadequate sedation, now, like she stepped in and she said what she wanted you guys for protocol. This is just what I found from my research. If it's inadequate sedation, you can repeat the dose and keep the range between 2 to 5 milligrams per kilogram after about 5 to 10 minutes, or an additional dose as needed, okay? Now, it's weird because the way that you said, Tammy, for the benzodiazepine was different from the research that I did for how to use it. Now, they insinuated from the research and a study in the guidelines that benzodiazepines should only be used for prophylactically for like emergence reactions. So you can use that prophylactically with the ketamine. Maybe give them the ketamine to calm them down, and then the benzodiazepine will help to prevent some of those emergent reactions, which is basically like some of those hyperexcitability from the post-ketamine. Obviously, go with what Tammy says. This is just from what research that she asked me to look up. So I don't know what your feeling is on that. But and renal failure, this is really important, especially when you're dosing drugs, because how do we eliminate like almost 99.9% of our drugs? What vital organ, anybody? I just said it, right? Yeah, kidney. Yeah, that's why it's so important to maintain good renal clearance and maintain good kidney health, and obviously liver, because liver is usually our active site for breaking down drugs so that they can either be in their inactive or active forms, okay? So it's very important to know that, you know, for any drug you're going to dose, always check the patient. Are they a renal disease patient? Do they have hepatic issues, which is your liver? Because it's very important when figuring out a dose for a drug. Luckily, in this case, you guys don't have to worry about it. There's no dose adjustments needed. Although it does say, because it is broken down by liver, it does say, and everywhere I found, no dose adjustments provided in the manufacturing label, which is the little package inserts that I'm sure you guys are all aware of, that comes in every box of drug that you open up. It specifically said that there's no dose adjustments, but Micromedics, which is a drug resource database, they suggested a reduction in the dose, yet they didn't provide any. They didn't have a specific dose. There's no protocols for it. So that's just maybe like a little FYI for you guys. I mean, if you wanted to, for like I said, for that secondary dose. You can, although it doesn't seem like you guys are going to do this, but I just wanted to put it in there for full. You can follow up. Let's say we have somebody that's just, you know, needs, maybe they need more, or you guys decide to do more of a maintenance continuous infusion because they're so far out there, right? They did suggest you could follow up after a single dose of 5 to 20 micrograms per kilogram per minute with or without supplementation of oxygen. So, but you're not going to be doing that, so don't worry about it.
Nope.
This is a pretty important one too, whether it's on the test or not. Pregnancy and breastfeeding. So there's a few things that I always want you guys to keep in the back of your mind, because this isn't just the nerdy pharmacy is coming at me, because this is what I have to go by. Every time I look at a drug, every time I look at a patient, these are like the little step things that I go. And this is good for you, whether you're on the job or whether you're at home with your kids, your wife, your family members. Always check, how's their renal? You know, are they pregnant? Are they breastfeeding? Are they looking to become pregnant? These are all things that can affect the dose of the drug, or whether this patient's going to take the drug or not. So pregnancy and breastfeeding is not recommended. It crosses the placenta. It can cause increased fetal risks. So definitely, guys, make sure if you got a patient, you never know. I mean, you never know. Always ask. If you're going to administer this drug, it's very important to ask any female, whether they feel offended or not. You got to ask them, are you pregnant? Are you pregnant? You got to. Okay? It may be tough, though, because of the state of mind they're in. But if you have somebody that's close by or with them or whatever, just try to find out, look at the profile, whatever it is. It's very important. With children, its initial is the same. It's the same, 4 to 5. 4 to 5 mg per kg IM single dose. The only difference is that they don't get offered a benzodiazepine prophylactically because of the safety and efficacy. Well, hold on, sorry. They don't get offered the benzo for the prophylactic emergency reactions. But I did want to follow up, even though it said the same dosings as the adults and geriatrics, safety and efficacy have not been established in children younger than 16 years old. So that's something to take into consideration. Now the toxicology. At high doses, ketamine is a sigma receptor agonist causing lethargy and coma. Now this is pretty important because there's no specific cutoff other than what you guys are told for your protocols. This is very, very important, muy importante, okay? In overdoses, the common side effects are sedation and respiratory depression. Make sure you guys instill that in the back of your head. You know, you could give one dose and it could be, you could have that 0.1% that it's too high of a level for them, unfortunately. So these are the two main things to look at, two common side effects to look at: sedation and respiratory depression. What level of sedation? Are they over-sedated, or are they having issues breathing? Okay. Toxicity treatment. Basically, if they are over-toxicated, there's a few different things. They have support management, decontamination, airway management, antidote, and monitoring of patient. Those are the things that you want to look at for treatment of any kind of toxicity levels. If it's mild to moderate for support, it's good symptomatic and supportive care. Basically, any kind of symptoms that they're alluding, we're going to treat that, and any kind of supportive care to prophylactically prevent anything else from happening, okay? Whatever that may be for that individual patient. And then severe is mainly symptomatic and supportive care. If the patients experience additionally like seizures and agitations, we could look at giving a benzodiazepine. If it's persistent seizures, we could look at barbiturates or the MJ juice. Anybody know what MJ juice stands for? Michael Jackson, that's right. Yep, the propofol, yep. And ketamine-induced dystonia. Basically, this is like rigid muscle, like extrapyramidal type syndrome side effects, locking jaw type stuff that could be caused by ketamine. One thing we could do is give diphenhydramine, okay, to help subdue those symptoms. Now, these are things that I looked at from the guidelines. It could be different from what you guys addressed. I just wanted to at least address it so they know for toxicity levels. Decontamination. You guys are paramedics. What's usually used for overdosing out in the field? Anybody know? It's the stuff you swallow and make them... Charcoal? Yeah, activated charcoal. Well, and that's in a lot of cases with a lot of overdoses, right? They use activated charcoal out in the field, and then they do the other method in hospital. What is it? I can't remember off the top of my head. What is it? Gastric lavage. That's correct. But they want to avoid it. And the reason why is because they want to avoid it both pre-hospital and hospital because patients are at high risk for aspiration. Patients generally do well with just the supportive care. Because we're putting them in that, we're decreasing that polysynaptic reflexes, it's also affecting organs in the body that normally, that aren't working as normal. So if we have a person that's puking up and coated with this coated charcoal or gastric, it can cause aspiration. You know, they're not going to be able to properly expel this. It's going to get back in the lungs, and then we're running into all sorts of other issues that I don't need to get into, and we could have issues. You know, that could lead to death, unfortunately. So we don't worry about decontamination. Airway management, assisted ventilation, and supplementation of oxygen. This one's rare that we would incubate them unless, what was that?
Intubate.
What did I say?
It auto-corrected.
Oh, did I? Yeah, okay. Incubation. Thank you. Thank you. So for the large overdoses, that's what I know, right? Yeah. Give me a swaddle stat. I can't believe I didn't see that. I even highlighted it red. That's awesome. Thanks, Tammy. Appreciate it. That is awesome. It's rarely used, but it's in scenarios where it's like, large overdoses, and patients that are experiencing like prolonged CNS and respiratory depression. Now, this is really important. This is why you need to know this. Antidotes, usually we have antidotes like for opioids, right? What's the one off the top of your head for like opioids? Okay. Exactly. Well, we don't have one for this one. That's why it's important to know the two side effects. What were the two side effects again? Sedation, respiratory depression, exactly. So there is no antidote. Monitoring of the patients. We're going to look at vital signs, mental status, pulse oximetry, obtain ECGs, and continuously monitor like cardiac symptoms. You want to also obtain electrolytes and blood glucose in patients with like altered mental status. Good morning, guys.
Hey, good. Sorry.
Hi. Oh, you guys.
You listen to them.
Medication safety. This is stuff good for you guys to know, especially if they have some of these indications or if they're on certain drugs. Contraindicated. It is highly contraindicated in high blood pressure patients. And patients hypersensitivity to ketamine, basically just having if they've had an allergic reaction to it in the past. Basically, what do you think we're going to do if the patient has high blood pressure and they're experiencing excited delirium? What do you think the first thing we're going to have to do? And they have high blood pressure. We're going to try to decrease the blood pressure. Now, I don't know about you guys being in the ER, being out in the field, but we would try to, if that was something we wanted to do, we would want to decrease the blood pressure. And then obviously we could administer the ketamine. But as I'm thinking about it, and the more with you guys being the paramedics, I thought there would be more ER as well here too. But yeah.
They don't let us do blood lighting.
No, that's fine. Just disregard the last 10 seconds of what you just heard. That's more the clinical side coming out in me. And I gotta make sure go ahead.
I haven't seen much excited delirium, but I would assume we wouldn't be able to get a blood pressure until ketamine's on board.
Exactly. That's what I'm saying, like out in the field where you guys are, it's a lot different. Obviously you're going to be just administering the injection.
We don't need a blood pressure before.
Don't worry about that. Don't worry about it. It's going to be tough. The patient's going to be non-compliant. This is me trying to give you extra information. Don't worry about that. Just worry about just administering it if the patient's experiencing those symptoms, okay? Next thing we got is precautions in patients with cardiovascular issues, neurological disorders, respiratory disorders, and some special populations like chronic alcoholism or acutely alcohol intoxicated. Some adverse effects that we can see, some common ones in patients with cardiovascular disease or hypertension, tachycardia. Neurologic would be emergence from the actual anesthetic, and then psychiatric signs or symptoms. Some serious ones to look for are like bradycardia, cardiac dysrhythmia, hypotension, and then a big one would be like anaphylaxis, like an immunologic reaction to it. And then, like I said, we keep going back to respiratory issues, apnea, laryngeal spasms, pulmonary edema, and respiratory depression. Bear with me, guys. We're getting there. We're almost there. Medication safety is continuing, and here's some of the major drug interactions. I don't expect you guys to memorize any of these, but I just wanted to put them up here so that you can see. What do we talk about? Sedation and respiratory depression. So if these patients are on morphine, or we're thinking about giving them morphine on top of that, or any kind of neurological like Aricept, the donepezil, anything respiratory depression or any kind of sedating, we always want to kind of keep in the back of our mind if the patient's on that, or if we're thinking about administering that in concomitant use with the ketamine, okay? There's some major interactions. Basically, it's going to worsen those symptoms, okay? Some monitoring parameters are going to be heart rate, blood pressure, respiratory rate, O2 stats, emergence reactions like we've said before. And cardiac functions should definitely be continuously monitored in patients, especially if they have high blood pressure or cardiac decompensation. So to answer your question for being out in the field, I think it'd behoove you to maybe continue to maybe monitor even once they got sedated, keep monitoring that blood pressure. So upon arrival, I'm assuming that's the scenarios that you guys are in. You can kind of keep them updated. Hey, we gave him ketamine. He's got a high blood pressure. When we took his stats, just as an FYI to let the nurses or whoever know. That way they know as well that, okay, we need to monitor this a little bit more closely because it's a severe contraindication. So hopefully that can help out with that question. All right, last but not least, we're getting down to it. I kind of like the, do not confuse, and I'm always kind of like that guy, like, wait, what? Ketalar, like we said, is the brand name for ketamine. Okay, Ketalar is the brand name for ketamine. Sometimes, it may seem like a huge difference when you're looking at it on the screen right now, but these are the top 2 drugs that get confused with it all the time when you reach into your med bag, okay? So always double check. Always double check. Make sure that the dose is right, double checking everything. Ketalar is not Keppra, Ketalar is not Ketorolac. I would see how the Ketorolac, other than you getting used to the vials, and that's one thing in pharmacy that they always tell us, do not get used to the vials, always read the drug name. Always. Because it may be different one day. Yes, sir.
I know we don't carry those other drugs, so you don't have to worry about it, but definitely when you're restocking the med, because I've restocked, for example, dopamine, and I've been getting dopamine before. Just make sure when you're actually getting the restock that you're having the right drug, so the next person who's giving it doesn't just assume that it's ketamine.
Yeah, that we have big issues, especially in clinical pharmacy with like ceftriaxone and cefepime. That happens a lot. You always just read the drug. Instill it in your mind now and just do it. Don't memorize the bottles. Patient education. This may be more so for our ER staffing members, but when early discharge is possible, advise them definitely make sure that they're not driving or doing any other hazardous activities for at least 24 hours after the ketamine administration. We can educate the patients about signs and significant reactions, one being like anaphylaxis, and then side effects patients may experience, fatigue, lack of appetite, nausea, and vomiting, and then definitely, and this is more so for your people at the hospital, if they have any kind of side effects, whether they're there or when they leave, severe dizziness, obviously if we notice they're passing out, difficulty breathing, tachycardia and bradycardia, arrhythmias, severe headaches, confusion, involuntary eye movements, and severe injection site irritations. Or even if you guys notice them out there. I think one might be like a quick reaction on injection site, note that, let them know. And that concludes it. There's my references that you guys can have for your likings. That's all, folks. And then, sorry guys, but it's quiz time. Sorry. Yes, sir. Yeah, any questions before we move forward?
Yeah, one question as far as, is this going to be included in the chemical restraint protocols?
No,
Excited delirium.
just for excited
Okay,
delirium.
so I mean, if you get a violent, stupid,
You're
patient,
gonna put them
excited
down with
delirium?
ketamine. You mean if they're excited delirium? Yeah, that's what it's for.
but I mean, if he's just a drug crazed, violent, swinging at you stuff.
Is it excited delirium? Is it excited delirium?
Yeah.
It's all answered in the.
If he's just intoxicated and obnoxious, no. That's what tasers are for.
All right, everybody's
Hold on just a second.
When do we get the tasers?
That's on my budget. But the police.
Yeah, I did the definition of excited delirium in the lecture,
Yeah.
but it is, you're right. It is very ambiguous.
Yeah.
It is very ambiguous.
Exactly.
I'm gonna leave that to Tammy for your guys' protocol to determine.
Who do
You
I
know,
like and who?
No, you can't just give ketamine to your buddy that's annoying and won't shut up,
Because then it takes the right out of service, right?
Hey, honestly, thanks, guys. I appreciate you guys listening to me talk. It's been a pleasure. I had fun doing this. This is something I'm passionate about, educating and teaching and helping people out from a therapeutic standpoint. Thank you very much, and you guys enjoy your day. Enjoy your day.